Welcome to our session on neonatal pharmacology principles. Understanding how medications behave in our tiny patients is critical, not just for the exam, but for safe practice. What makes neonatal pharmacology so challenging is that these aren't just small adults. Their physiology is completely unique and constantly changing. Let's break it down together. By the end of this presentation, you'll understand the key pharmacology concepts you need for both clinical practice and the exam. We'll cover pharmacokinetics and pharmacodynamics specific to neonates. You'll learn how a neonate's unique physiology affects drug behavior, which is incredibly important since what works in adults often doesn't translate directly to babies. We'll also cover safe medication administration practices, how to calculate appropriate dosages, and how to recognize adverse reactions. These are skills you'll use every single day in practice. So, why is neonatal pharmacology different from adult pharmacology? First, neonates undergo rapid physiologic changes that affect how drugs move through their bodies. A medication might behave one way in a 24-week preemie, another way in a term infant, and yet another way in that same baby a week later. What's even more challenging is that we have limited clinical trial data in this population. Most medications are used off-label. This means we're often making our best clinical judgment based on limited evidence. It's also why medication errors are unfortunately common in NICUs. Understanding these principles isn't just academic. It's about patient safety. Let's start with pharmacokinetics, which describes what the body does to the drug. Think of it as the ADME process: absorption, distribution, metabolism, and excretion. It's the mathematical relationship between the dose we give and the resulting blood levels over time. Absorption is how the drug moves from the administration site into circulation. Distribution is how it travels to where it needs to work. Metabolism is how the body transforms the drug. And excretion is how it gets rid of it. Each of these processes works differently in neonates than in adults. And you absolutely need to understand these differences. Drug absorption is the process of moving medication from the administration site into circulation. In neonates, several factors make this process unique. The route of administration obviously matters a lot, but what's especially important in babies is blood flow to the absorption site. Remember that neonates often have compromised peripheral perfusion, especially when they're sick. Gastric pH is higher in neonates compared to adults, which affects how certain drugs are absorbed. Gastric emptying time is delayed and intestinal motility is decreased. All of these factors make drug absorption much less predictable in neonates than in adults. You need to keep this in mind when choosing administration routes. Each route has different absorption characteristics in neonates. Intravenous administration gives 100% bioavailability. It's our reference standard because the drug goes directly into circulation. Oral administration is tricky in neonates due to variable absorption, affected by that higher gastric pH and slower motility we just discussed. Here's a huge exam tip. The intramuscular route has the most erratic absorption in neonates. Poor perfusion limits absorption, there's risk of tissue damage, and neonates have limited muscle mass. The subcutaneous route also has variable absorption due to perfusion issues. When possible, IV is almost always preferred for predictable drug delivery. Bioavailability refers to the amount of drug that actually reaches circulation. As we just mentioned, intravenous administration has 100% bioavailability, since it goes directly into the bloodstream. Oral bioavailability is affected by multiple factors, but one that's especially important is first-pass metabolism through the liver. When a drug is given orally, it gets absorbed from the GI tract and goes straight to the liver via the portal circulation before reaching the systemic circulation. The liver may metabolize a significant portion before it even gets to work. This is why some drugs require higher oral doses than IV doses to achieve the same effect. This concept is crucial for understanding why route changes require dose adjustments. Now, let's talk about distribution, which is the movement of a drug to tissues or its site of action. This is affected by several factors: lipid solubility, molecular size, ionization, and membrane permeability. Here's a critical point. Only free, unbound drug crosses membranes, and only free drug can exert a pharmacologic action. Drug that's bound to proteins like albumin is essentially inactive. This becomes particularly important in neonates, who have different protein levels and binding capacity than adults. Understanding how distribution differs in neonates helps explain why standard dosing often doesn't apply. Neonatal physiology significantly affects drug distribution. Total body water is much higher in neonates, about 85% in preterm infants and 75% in term infants, compared to only 50 to 65% in adults. Body fat content is lower in newborns. Protein binding capacity is decreased, meaning more drug remains unbound and active. Extracellular fluid volume is increased. The blood-brain barrier is more permeable, allowing more drugs to reach the central nervous system. All these differences mean drugs distribute very differently in neonates than in adults. This is why we can't just scale down adult doses by weight. The entire distribution pattern is different. Volume of distribution is a critical concept that appears frequently on the exam. It's a hypothetical volume needed to contain the drug at the measured concentration, not an actual physical space. This is affected by gestational age and fluid shifts. Water-soluble drugs have a larger volume of distribution in neonates due to their increased extracellular fluid. This larger volume of distribution decreases peak values and affects drug excretion. Conversely, lipophilic drugs have a smaller volume of distribution in preterm or IUGR infants because they have less body fat for the drug to distribute into. This concept directly affects your initial dosing decisions. Larger volume of distribution often means you need a larger milligram per kilogram loading dose to achieve therapeutic levels. Neonates have lower circulating proteins, especially albumin, and the binding affinity of these proteins is lower. This means more free drug is available for distribution to tissues, pharmacologic effect, and metabolism and excretion. A critical fact: protein-bound drug is inactive, while free drug exerts the pharmacologic effect. In neonates, there's also competition with bilirubin for protein binding sites, which can displace drugs and increase free drug concentration. This is particularly important with highly protein-bound drugs, because small changes in binding can cause large changes in free drug concentration, potentially leading to toxicity. Metabolism, or biotransformation, is the process of converting drugs into metabolites. Metabolism primarily occurs in the liver, but also happens in the kidney, intestine, and lungs. There are two major phases. Phase 1 involves oxidation, reduction, and hydrolysis, while Phase 2 involves conjugation reactions. A key point: the rate of drug metabolism is low at birth, and especially low in premature infants. This means drugs stay in their system longer. Another concept is that enzymes mature at different rates during development. This variable maturation can make drug metabolism quite unpredictable in neonates. Phase 1 metabolism is mediated by cytochrome P450 enzymes. These enzymes convert drugs through oxidation, reduction, and hydrolysis. In neonates, CYP450 enzymes are present at birth, but have reduced activity. The maturation of these enzymes is variable. Some develop quickly, others take months. Activity generally increases with postnatal age. Examples of drugs metabolized through Phase 1 include phenytoin, phenobarbital, diazepam, and indomethacin. An important concept is caffeine metabolism, which follows zero-order kinetics in neonates. This means a constant amount, not percentage, is eliminated per unit of time, regardless of concentration. This is why caffeine can accumulate and cause toxicity if given too frequently. Phase 2 metabolism involves conjugation processes, which are also developmentally regulated in neonates. Glucuronidation is limited in neonates. This is important because many drugs rely on this pathway. Other Phase 2 processes include acetylation, methylation, glycine conjugation, glutathione conjugation, and sulfate conjugation. Interestingly, sulfate conjugation is more active at birth than other pathways. Morphine and acetaminophen are examples of drugs metabolized through glucuronidation. Because this pathway is limited, these drugs may have prolonged effects in neonates. These developmental considerations significantly affect dosing decisions, particularly for drugs heavily dependent on phase 2 metabolism. Multiple factors can alter drug metabolism in neonates. Age-related enzyme maturation is crucial. Both gestational age and postnatal age matter. Enzyme systems develop rapidly in the first month of life, which means dosing may need adjustment as the infant matures. Nutrition status affects metabolic capacity. Illness, particularly liver disease, can profoundly impact metabolism. Drug interactions can inhibit or induce metabolic enzymes. Hepatic blood flow determines how quickly drugs reach metabolizing enzymes. Genetic variation, pharmacogenomics, is becoming increasingly recognized as important. An important concept: liver dysfunction prolongs drug half-life, requiring dose adjustments to prevent toxicity. Drug excretion in neonates primarily occurs through the renal system. Other routes include biliary, pulmonary, and cutaneous excretion, but the kidneys are most important for most drugs. Renal mechanisms include glomerular filtration, active secretion at the proximal tubule, and reabsorption at the distal tubule. A key concept: neonates have reduced renal function, which significantly affects drug elimination. This is particularly important for drugs primarily eliminated unchanged through the kidneys, such as aminoglycosides and vancomycin. These drugs require careful dosing and monitoring to prevent accumulation and toxicity. It is important to understand factors affecting renal drug clearance. Neonates have reduced glomerular filtration rate, reduced tubular secretion, and reduced creatinine clearance compared to adults. These parameters improve with gestational and postnatal age, but remain below adult values for months. Pathologic processes can further impair renal function, including hypoxemia, poor perfusion, hypothermia, concurrent renal disease, and exposure to nephrotoxic drugs. A key concept: renal function is the primary predictor of vancomycin clearance. This is why we adjust vancomycin dosing based on renal function and monitor levels closely. Understanding these factors helps predict drug clearance and guides dosing decisions. Pharmacokinetic models help us understand how drugs are eliminated. In zero-order, saturation, kinetics, a constant amount of drug is eliminated per time unit, regardless of concentration. This happens when metabolic pathways become saturated. Examples include caffeine, phenytoin, and furosemide in neonates. In first-order kinetics, a constant percentage of drug is eliminated per time unit, proportional to concentration. Most drugs follow first-order kinetics, meaning half-life is constant regardless of dose. Multi-compartment first-order kinetics describes drugs that distribute between central and peripheral compartments before elimination. Understanding these models helps predict drug behavior over time. Half-life is the time it takes for plasma concentration to decrease by 50%. It's affected by both volume of distribution and clearance, factors we've discussed as being significantly different in neonates. The formula is T1/2 equals 0.693 divided by the elimination rate constant. Half-life has important clinical implications. It determines appropriate dosing intervals, predicts how long it will take to reach steady state, and guides dose adjustments. A key relationship: it takes about 4 to 5 half-lives to reach steady state with repeated dosing. For drugs with long half-lives in neonates, this may mean steady state isn't reached for days or even weeks. Steady state occurs when the rate of drug administration equals the rate of elimination. Typically, steady state is reached after 4 to 5 half-lives of consistent dosing. At steady state, peak levels are consistent after each dose, and trough levels are consistent before each dose. Here's a key concept: steady-state concentration is determined primarily by drug clearance, not half-life. Many students mistakenly focus on half-life, but clearance is the key determinant. Understanding steady state is essential for therapeutic drug monitoring because we typically want to measure drug levels once steady state has been achieved for the most reliable results. Now let's shift to pharmacodynamics, which describes the relationship between drug concentration and effects on the body. This includes both therapeutic and toxic effects. Drug-specific properties include mechanism of action, potency, efficacy, and toxicity profile. In neonates, pharmacodynamics can be altered due to differences in receptor binding, receptor density, and the maturation of these systems. For example, some receptors may be more or less sensitive in neonates compared to adults. While pharmacokinetics tells us what the body does to the drug, pharmacodynamics tells us what the drug does to the body. Both are essential for understanding drug therapy in neonates. Antimicrobial pharmacodynamics involves several crucial concepts. The minimum inhibitory concentration is the lowest concentration that prevents visible bacterial growth. Peak concentration is the highest drug level achieved. Area under the curve measures total drug exposure over time. Post-antibiotic effect is continued bacterial suppression after the drug is removed. Different antibiotics work in different ways. Aminoglycosides like gentamicin demonstrate concentration-dependent killing, where efficacy relates to the peak concentration relative to MIC. Beta-lactams like ampicillin show time-dependent killing, where efficacy depends on how long concentration remains above the MIC. Vancomycin combines both effects, where efficacy relates to AUC-MIC ratio. Understanding these patterns guides dosing strategies. When selecting a route, consider the patient's condition, drug properties, how quickly you need effect, and available access. Volume limitations are important. For example, maximum IM injection in the anterior thigh for a 1,400-gram neonate is only 0.3 milliliters, and 0.5 milliliters for a full-term infant. IV administration in neonates requires slow infusion rates and minimal flush volumes to avoid fluid overload. Proper documentation is essential, particularly for controlled substances. Always double-check high-alert medications like opioids, insulin, heparin, and vasopressors. Route selection significantly impacts both onset of action and bioavailability, so choose wisely based on the clinical situation and drug properties. Dosing must be individualized based on weight, usually in milligrams per kilogram, gestational age, postnatal age, clinical condition, and organ function. A key concept, dose and interval adjustments are necessary as the neonate matures, because metabolic and excretory functions improve rapidly during the first weeks of life. Therapeutic response should be monitored closely, and plasma drug concentration should be measured when indicated, particularly for drugs with narrow therapeutic indices. Remember that standard pediatric dosing rarely applies directly to neonates. Always consult neonatal-specific references for dosing guidance. The purpose of TDM is to optimize therapy and prevent toxicity by measuring drug levels and adjusting doses accordingly. Indications for TDM include drugs with narrow therapeutic indices, variable pharmacokinetics, unclear dose-response relationships, and high risk of toxicity. Examples include aminoglycosides, vancomycin, phenobarbital, and caffeine. A key concept: peak levels reflect volume of distribution, while trough levels determine drug adequacy. Another important point: therapeutic ranges for neonates may differ from those for adults due to developmental differences in pharmacokinetics and pharmacodynamics. TDM is particularly important in neonates because of their rapidly changing physiology. Interpreting peak and trough levels are another important concept. Peak levels should be drawn after the distribution phase, alpha phase, and at the beginning of the elimination phase, beta phase. This timing reflects maximum drug effect. For gentamicin, this is typically 30 minutes after completing a 30-minute infusion. Trough levels should be drawn just before the next scheduled dose to reflect drug elimination and predict accumulation. A key point: drawing levels at the correct times is critical for accurate interpretation. Incorrect timing can lead to misinterpretation and inappropriate dose adjustments. Laboratories often provide recommended sampling times for specific drugs to ensure accuracy. Medication safety in the NICU is a critical topic for clinical practice. Neonates are a high-risk population for medication errors due to weight-based dosing, decimal point calculations, and their physiologic vulnerability. The most common errors are dose calculation errors, particularly tenfold dosing errors from misplaced decimal points. Other common errors include wrong infusion rates and wrong concentrations. Prevention strategies include independent double checks for high-alert medications, standardized concentrations, smart pumps with built-in safety limits, and barcode medication administration. Remember that preventing medication errors is a shared responsibility among all healthcare providers, and having strong safety systems in place is essential. Key dosing calculations are essential for safe practice. These include weight-based dosing in milligrams per kilogram or micrograms per kilogram, body surface area-based dosing in milligrams per meter squared, less common in neonates, and creatinine clearance adjustments for renally eliminated drugs. Infusion rate calculations are particularly important for continuous medications, including converting from milligrams per kilogram per minute to milliliters per hour based on concentration. IV push rates and dilution requirements must be carefully calculated to avoid rapid infusion of medications that could cause hemodynamic instability. Developing a systematic approach to calculations and always double-checking your math are essential safety practices. Drug tolerance and withdrawal are important clinical considerations. Tolerance occurs when there's a decreased response to a drug over time, usually with long-term therapy. Higher doses may be needed to achieve the same effect. This happens due to receptor-drug interactions and whether the drug acts as an agonist or antagonist when bound to receptors. Opioid tolerance is common with long-term use in the NICU. Withdrawal symptoms can occur with abrupt discontinuation of medications on which a patient has developed dependence. Weaning strategies include gradual dose reduction, increasing intervals between doses, and tapering regimens. This is particularly important for sedatives and analgesics used for prolonged periods. Let's review the essential concepts for the exam. Pharmacokinetics is significantly altered in neonates across all ADME processes: absorption, distribution, metabolism, and excretion. Water-soluble drugs have a larger volume of distribution in neonates due to higher total body water. Reduced protein binding means more free drug is available for effect and elimination. Immature hepatic metabolism and renal clearance prolong drug half-lives. First-order kinetics means a percentage of drug is eliminated over time, regardless of dose. The intramuscular route has the most erratic absorption in neonates. Steady-state concentration is determined primarily by clearance, not half-life. Therapeutic drug monitoring guides safe dosing. These principles will help you both on the exam and in clinical practice, where your understanding directly impacts patient safety. The neonatal nurse practitioner is considering gentamicin dosing for a premature neonate. The primary determinant of steady-state concentration for this antibiotic is clearance half-life, volume of distribution. The correct choice is clearance. This question is testing your understanding of pharmacokinetic principles related to steady-state concentration. Clearance is correct because it represents the body's ability to eliminate the drug, which directly determines the steady-state concentration. At steady state, the amount of drug administered equals the amount eliminated, and clearance is the mathematical determinant of this relationship. Half-life is incorrect because, while it affects how quickly steady state is reached, typically 4 to 5 half-lives, it does not determine the actual concentration at steady state. Volume of distribution is incorrect because it affects the initial concentration after dosing and loading doses, but not the steady-state concentration with maintenance dosing. A preterm neonate receiving caffeine therapy develops persistent tachycardia, with heart rates consistently above 200 beats per minute. This adverse effect most likely represents first-order elimination, saturation, phase 2 metabolism impairment, zero-order kinetics, saturation. The correct choice is zero-order kinetics saturation. This question is testing your knowledge of drug metabolism patterns and adverse drug reactions. Zero-order kinetics saturation is correct because caffeine follows zero-order kinetics in neonates, meaning a constant amount, not percentage, is eliminated regardless of concentration. When caffeine accumulates beyond the neonate's metabolic capacity, toxic effects like tachycardia occur. First-order elimination saturation is incorrect terminology. First-order elimination means a constant percentage is eliminated, which doesn't become saturated. Phase 2 metabolism impairment is incorrect because caffeine is primarily metabolized through phase 1 CYP450 pathways, not phase 2 conjugation. When administering medication to a neonate, the route associated with the most erratic absorption is intramuscular, intravenous, subcutaneous. The correct choice is intramuscular. This question is testing your knowledge of medication administration routes in neonates. Intramuscular is correct because neonates have poor muscle perfusion, limited muscle mass, and variable blood flow to muscles, making absorption highly unpredictable and erratic. Intravenous is incorrect because it provides 100% bioavailability with no absorption variability, since the medication enters circulation directly. Subcutaneous is incorrect because while subcutaneous absorption can be variable in neonates, it is generally more predictable than intramuscular administration. When protein binding of a medication is reduced in a neonate, which of the following occurs? Decreased pharmacologic effect, increased free drug available, prolonged alpha phase distribution. The correct choice is increased free drug available. This question is testing your understanding of drug distribution and protein binding in neonates. Increased free drug available is correct because only unbound, free drug exerts pharmacologic effects and crosses membranes. Reduced protein binding means less drug is bound to proteins like albumin, resulting in more free drug. Decreased pharmacologic effect is incorrect because reduced protein binding actually increases pharmacologic effect due to more free drug availability. Prolonged alpha phase distribution is incorrect because reduced protein binding typically shortens the distribution phase since more drug is immediately available to tissues. The bioavailability of an oral medication in neonates is primarily limited by first-pass metabolism through the liver, glomerular filtration rate, water solubility of the drug. The correct choice is first-pass metabolism through the liver. This question is testing your knowledge of factors affecting drug absorption and bioavailability. First-pass metabolism through the liver is correct because after oral administration, drugs are absorbed from the GI tract into the portal circulation and pass through the liver before reaching systemic circulation. During this first pass, significant amounts of drug may be metabolized, reducing bioavailability. Glomerular filtration rate is incorrect because while it affects drug elimination, it doesn't directly impact oral bioavailability. Water solubility of the drug is incorrect because although it can affect absorption from the GI tract, it's not the primary limitation for oral bioavailability in neonates compared to first-pass metabolism.